Assalamu alaikum. Dear students, I'm Dr. Zaheer Ahmad and I'm a neurophysician in Light Hospital, Faisalabad. I hope all of you are doing fine. Today we are going to discuss a very important topic, life-threatening disease, that is subarachnoid hemorrhage. So let's have a look at this case history. A 25-year-old female presented to accident and emergency department with complaints of sudden onset very severe occipital headache, which kept on progressing for 1 hour and then became steady, associated with nausea and vomiting. It's the worst headache she ever had, according to the patient. On examination, she has a pulse of 88, blood pressure 150 by 90, temperature is 98 degrees Fahrenheit, and there are signs of nasal irritation. What is your clinical diagnosis? What investigation will you perform immediately? How will you manage this patient? So these are the 3% that you will be able to answer at the end of this discussion. What is a subarachnoid hemorrhage? Basically, it is a rupture of one of the vessels and bleeding into the subarachnoid space. And usually it's a non-traumatic hemorrhage. Subarachnoid hemorrhage accounts for 3% of stroke. So these are the major causes: sacral Barry aneurysms, arteriovenous malformations. No lesions are found in 15% of the cases. So these sacral Barry aneurysms has a very important association. Adult polycystic kidney disease. जिन लोगों को adult polycystic kidney disease होती है, उन लोगों के अंदर देखा गया है कि अचानक से sudden death हो जाती है. तो this sudden death is attributed to rupture of one of these sacral Barry aneurysms. तो sometimes आपको एग्जाम में जब स्नैरियो आता है तो आपको एडल्ट पॉलीसिस्टिक किडनी डिजीज का स्नैरियो आता है और उसके अंदर सडन डेथ किसी फैमिली मेंबर की होती है या पेशेंट को सिवियर हेडेक हो जाता है. So you have to keep this adult polycystic kidney disease in mind. This is a very important diagram. You are all familiar with circle of Willis. So this is internal carotid artery. This is middle cerebral artery. This is anterior cerebral artery. And this anterior cerebral artery is connected to this middle cerebral artery through anterior communicating artery. This is posterior cerebral artery, and this posterior cerebral artery is connected to this middle cerebral artery through posterior communicating artery. And the rest is simple: superior cerebellar artery, basilar artery, pontine branches of the basilar artery, and so the rest of the circle of Willis. Subarachnoid hemorrhage is usually caused by sacral aneurysms, and these sacral aneurysms are located on the circle of Willis. Its most common sites are junction of anterior cerebral artery and anterior communicating artery, junction of posterior cerebral artery and internal carotid artery, that is posterior communicating artery, and at the bifurcation of middle cerebral artery. So these are the most common sites. We'll discuss these sites in our next slide on a detailed diagrammatic picture. So aneurysms cause symptoms by pressure on surrounding structures. For example, posterior communicating artery aneurysms causes painful third nerve palsy. So this is a common scenario, and we need to identify this scenario as soon as possible, because if we fail to recognize this scenario in time, it may prove fatal to the patient. होता क्या है कि कोई यंग सा बंदा होगा, ठीक है, वो आपके पास आएगा डिप्लोपिया की कंप्लेन के साथ और साथ ही सिवियर हेडेक की कंप्लेन के साथ दिस आई पेन. तो you need to get an immediate imaging of the brain, especially an angiogram, CT angiogram or MR angiogram, to look for this posterior communicating artery aneurysm. And if you identify this posterior communicating artery aneurysm, we can institute treatment in time, and we may potentially save a life. So these aneurysms cause subarachnoid hemorrhage by spontaneous rupture. Where these aneurysms are located, look at this. This is anterior cerebral artery, and this is anterior communicating artery. And here at the junction, the most common site of aneurysm formation. This is middle cerebral artery and posterior communicating artery, and here on this junction 20% of the aneurysms are present. And this is middle cerebral artery, and this is the bifurcation of middle cerebral artery, and here the 34%. and rarely these are present on the bifurcation of the basilar artery. So these are the common sites of arteriovenous malformations are lesions of developmental anomalies, and these are found within the brain. And these can present with pressure symptoms, focal epilepsy, subarachnoid hemorrhage due to rupture of the AVM, and sometimes they are cavernous hemangioma. So clinically, subarachnoid hemorrhage presents with a sudden onset severe headache, which is described by the patient as the worst headache of life. And it is a thunderclap headache, like it occurs like thunder cloud, and it is followed by vomiting. In few cases, there may be loss of consciousness. Focal neurological signs may be present, like cranial nerve palsies. Due to irritation of the meninges, meningeal irritation के signs भी हो सकते हैं. Sometimes there are pre-retinal hemorrhages, subhyalite hemorrhages can be present. Focal seizures occurs in less than, focal or generalized seizures occur in less than 10% of the case. Sentinel headaches, बच्चों इस term को याद कर लें, इस term को identify कर लें. Before the major hemorrhage occurs, a few weeks or months back, there are some sudden onset, which is not so severe like a major hemorrhage, लेकिन ऐसे headaches होते हैं, ठीक है. और अगर हम इन हेडेक्स को आइडेंटिफाई कर लें, इस पेशेंट को इसी स्टेज पे इन्वेस्टिगेट करके ट्रीट कर दें, तो हम मेजर हेमरेज को अवॉइड कर सकते हैं. वी कैन सेव द लाइफ ऑफ द पेशेंट. सो दीज हेडेक्स इन आर कॉल्ड सेंटिनल हेडेक्स. सेंटिनल का मतलब होता है संतरी, जो चौकीदार होता है, जो पहले आपको एक मुनादी देता है कि अब मेजर हेमरेज होने वाली है. सो दिस इज व्हाई दीज आर कॉल्ड द सेंटिनल. So the investigation of choice is CT scan brain, and its sensitivity is very high if performed early. अगर हम within 6 hours इसको कर लें तो it can identify more than 95% of cases. In 5% of the cases, CT scan may be normal, and in that case we perform lumbar puncture, and CSF shows the presence of xanthochromia. ये जो लंबर पंक्चर है, ये 12 घंटे के बाद परफॉर्म करना चाहिए, ठीक है. एक पेशेंट को बहुत स्वेयर हेडेक हुआ, आपने सीटी स्कैन परफॉर्म किया, सीटी स्कैन नॉर्मल आता है. अगर सीटी स्कैन नॉर्मल आता है, द नेक्स्ट स्टेप शुड बी अ लंबर पंक्चर फॉर एग्जामिनेशन ऑफ xanthochromia एंड CSF आफ्टर 12 आवर्स. ओके. एंड और याद रखें, ये xanthochromia जो है ये 14 दिन तक मौजूद हो सकता है, ठीक है. So after that, brain imaging and angiography should be performed. It could be CT angiogram, it could be an MRI angiogram, or it could be a catheter angiogram, or it could be a digital subtraction angiogram. तो ये तीन चार किस्म के एंजियोग्राम्स हैं जो आप इन पेशेंट्स के अंदर परफॉर्म कर सकते हैं. The choice depends upon the availability and invasiveness of these investigations. So how do you grade subarachnoid hemorrhage? जितना ज़्यादा ग्रेड होगा उतनी ज़्यादा mortality होगी. So grade 1 is asymptomatic or mild headache and slight neckal rigidity. Grade 2 is severe headache, stiff neck, no neurologic signs except cranial nerve palsies. Grade 3 is drowsy or confused patient with mild focal neurological deficits. Grade 4 is stuporous and moderate or severe hemiparesis. And 5 is comatose patient with decerebrate posture. So these are the Hunt and Hess grading system for patients with subarachnoid hemorrhage. So this is the CT scan of a patient with in these sulci and gyri. You will identify the presence of blood. This hyperdensity is basically the presence of blood in sulci. And this, here you can see there is some blood. Here you can see this is also filled with blood. So this is, and here you can see there are clots of this blood. These clots are basically indicate sometimes the site of hemorrhage as well. And this is intraventricular extension. So this is an angiogram. Here you can see that this is the aneurysm. This is a giant aneurysm on the posterior communicating artery. And here you can see there is another aneurysm, and this aneurysm is located at the bifurcation of middle cerebrum. So what other things you have to do? You have to do monitoring for vasospasm, and this is done through two modalities. Transcranial Doppler. This can tell us whether there is a vasospasm. Vasospasm क्या होता है? जब blood subarachnoid space में जाता है, it acts as an irritant. Okay, and because of this irritation, the vessels may go into spasm. उसकी वजह से क्या हो सकता है? Delayed cerebral ischemia हो सकता है, infarction हो सकता है. So transcranial Doppler and brain and vascular imaging, which includes CT angiogram, MR angiogram, digital subtraction angiogram, or catheter angiography. This catheter angiography is invasive. These other three are non-invasive. CT angiogram and MR angiogram are commonly available. Digital subtraction angiogram is less commonly available, but still it's and catheter angiography is invasive. You have to perform electroencephalogram for seizures. So अगर किसी को seizures नहीं हो रहे लेकिन electroencephalogram पे epileptiform activity आ रही है, you have to give prophylactic anti-epileptic therapy. और अगर किसी को seizures हो रहे हैं तो फिर तो आपको देनी ही देनी. Frequent neurochecks and status monitoring to detect delayed cerebral ischemia. अगर किसी पेशेंट को पहले से कार्डिक डिस्फंक्शन है तो बच्चों ऐसे पेशेंट के लिए आपने ईसीजी करवानी है. Subarachnoid hemorrhage में ECG changes common होते हैं. They can be ST segment depression, elevation भी हो सकती है, ST T wave inversions हो सकती हैं, tachycardia हो सकता है. Tropi can be raised, even it can cause a myocardial infarction. And if the patient is already having a ventricular dysfunction, the patient may go into failure. Echocardiography is also necessary. So this is the Fisher grade of cerebral vasospasm risk in subarachnoid hemorrhage. Grade 1, group 1 is no blood detected. इसमें risk बहुत कम होता है vasospasm का. If there is diffuse deposition or thin layer with all vertical layers in interhemispheric fissure, insular cistern, ambient cistern less than 1 mm thick. यानी blood की layer जितनी thin होगी उतना chance कम होगा vasospasm का. 3. अगर क्लॉट बन गया या वर्टिकल लेयर्स मोर देन 1 mm थिकनेस की बन गई, there will be more chance of vasospasm. And group 4 is intracerebral or intraventricular clot with diffuse or no subarachnoid blood. तो इसमें सबसे ज्यादा चांस होगा vasospasm. So how will you manage subarachnoid hemorrhage? You have to maintain airway, breathing and circulation of the patient. This should be your first priority. If the patient is having seizures, तो आपने उसको anti-epileptic drugs देनी है. You may prescribe levetiracetam or valproic acid. So these drugs should be preferred. Phenytoin should not be given because this may worsen the vasospasm. And subarachnoid hemorrhage, if possible, should be referred to a specialist care unit. उसकी वजह क्या होती है? For example, एक मेडिकल वार्ड है, उसके अंदर आपके पास क्लिपिंग या क्वाइलिंग की फैसिलिटी नहीं है, तो definite management of this patient will be delayed, resulting in more mortality. And if possible, blood pressure should be controlled. Systolic को हमने less than 160 रखना है, या फिर mean arterial pressure को less than 110 रखना है. Labetalol should be used for this purpose. Nitrates should be avoided. Nitrates से क्या होता है? Vasodilatation होती है, cerebral blood flow बढ़ता है, cerebral perfusion pressure बढ़ जाता है और उसकी वजह से intracranial pressure raise हो जाता है. तो nitrates should be avoided. हर किस्म के एंटीकोगुलेंट्स और एंटीस्केमिक्स तो स्टॉप. डीवीटी प्रोफिलैक्सिस, आप एंटीकोगुलेंट्स नहीं दे सकते, तो क्या करते हैं? ऐसे पेशेंट्स को इलास्टिक ग्रेजुएटेड कंप्रेशन स्टॉकिंग्स पहनाएं या न्यूमेटिक कंप्रेशन डिवाइसेस होती हैं जो कि हमारे लेग्स के अंदर ब्लड फ्लो को कायम रखती हैं. तो DVT prophylaxis with compression stockings और pneumatic compression devices. एंड हाई रिस्क पेशेंट्स के अंदर आपने एंटीसीयर ड्रग्स प्रोफिलैक्टिकली भी देनी होती हैं. यू हैव टू मेंटेन यूवोलीमिया. ठीक है, you are not supposed to cause hypervolemia because this may increase the risk of blood. लेकिन अगर पेशेंट को डिहाइड्रेशन होगी तो पेशेंट के वेजोस्पाज्म और डिलेड सेरेब्रल इस्कीमिया के चांसेस बढ़ जाएंगे. So you have to maintain euvolemia with adequate hydration, usually with normal saline. So normal saline should be given. This nimodipine is a calcium channel blocker, 60 milligram 4 hourly, starting within 48 hours up to 21 days. तो 21 दिनों के लिए आपने निमोडिपिन देनी है. निमोडिपिन क्या करती है? पहले तो ये सोचा जाता था कि निमोडिपिन चूंकि कैल्शियम चैनल ब्लॉकर है, ये एक वेजोडाइलेटर है, तो ये वेजोस्पाज्म को प्रिवेंट करती है. बट दिस हैज नॉट प्रूवन इन प्रैक्टिस, बट इट डिक्रीजेस द मॉर्टेलिटी. तो निमोडिपिन देने से मॉर्टेलिटी कम हो जाती है. हेडेक्स के लिए ओपिएट्स यूज करने हैं. यू आर नॉट सपोज्ड टू यूज एस्प्रिन, दिस इज एन एंटीप्लेटलेट ड्रग. एंड सेड्स को भी अवॉइड करें, आइदर एसिटामिनोफेन और पैरासिटामोल और ओपिएट्स. स्टूल सॉफ्टनर शुड बी गिवन. स्टूल सॉफ्टनर देने का क्या मकसद है कि पेशेंट को ताकि एक्सर्ट ना करना पड़े. इफ द पेशेंट एक्सर्ट्स, ड्यूरिंग एक्सर्शन इंट्राक्रैनियल प्रेशर इंक्रीजेस and chances of rebleed also increases. The patient should be on bed rest. Gastric ulcer prophylaxis should be given, though it is controversial, but should be given. Definite management is with surgical clipping or coiling of the aneurysm as soon as possible. And if this clipping or coiling is not possible immediately, then antifibrinolytic therapy, tranexamic acid or aminocaproic acid should be given for 72 hours. लेकिन आप antifibrinolytic therapy को 72 hours से ज़्यादा के लिए नहीं दे सकते. So these are the complications. The most common and the most fearsome complication is rebleed. तो अगर आपके पास एक पेशेंट सबरेक्नाइड हेमरेज का है और उसको दोबारा से स्वेयर हेडेक हो जाता है, या उसका कॉन्शियस लेवल फॉल करता है, उसको सीयर्स हो जाते हैं, उसका मेंटल स्टेटस चेंजेस आ जाती हैं, यू शुड परफॉर्म एन इमीडिएट सीटी स्कैन ऑफ द ब्रेन टू लुक फॉर रीब्लीड. अगर आपको सीटी स्कैन पे ब्लड नहीं मिलता तो लेस लाइकली है कि उसको रीब्लीड हो. रीब्लीड आपको लंबर पंक्चर पे नजर नहीं आता क्योंकि xanthochromia is present in CSF up to 14 days. इसलिए आप xanthochromia के जरिए रीब्लीड को डायग्नोज नहीं कर सकते. You have to take the help of CT brain imaging. The second complication is vasospasm. It is because of the irritation of the cerebral vessels because of the presence of blood in subarachnoid space. Vasospasm होगा, and sometimes this vasospasm is of such a severity that you get a cerebral infarction. ठीक है? And sometimes you have to perform an endovascular intervention to relieve this spasm. इस spasm को prevent करने के लिए आप nimodipine भी दे सकते हैं. Sometimes there are delayed cerebral ischemic changes. Hydrocephalus हो सकता है. ठीक है? It can be it is usually of non-communicating variety. जो सुपीरियर सैजिटल साइनस के अंदर अरेक्नॉइड ग्रैनुलेशंस हैं जिनके जरिए CSF अब्जॉर्प्शन होती है, वो ब्लॉक हो जाती हैं, तो हाइड्रोकेफलस हो जाता है. And to treat this hydrocephalus, you may need to put in a ventriculostomy, or you may do VP shunting, ventriculoperitoneal shunting. अगली स्लाइड में हम डिस्कस करते हैं. पेशेंट को हाइपोनेट्रीमिया हो सकता है साथ की वजह से, सिंड्रोम ऑफ इनअप्रोप्रिएट ADH secretion. तो देयर इज a hypothalamic pituitary axis damage and patient may go into hyponatremia. तो ऐसे पेशेंट्स को आपको वाटर रिस्ट्रिक्ट. The patient may have seizures, anti-epileptic drugs देंगे. Sometimes हम prophylactic and anti-seizure drugs भी दे सकते हैं अगर इलेक्ट्रोएन्सेफेलोग्राम के ऊपर एपिलेप्टिफॉर्म एक्टिविटी आ रही है। हाइपरनेट्रीमिया को वाटर रिस्ट्रिक्शन के साथ ट्रीट करते हैं। कार्डियोपल्मोनरी अबनॉर्मेलिटीज, आपको पहले बताया कि ऐसे पेशेंट जिनको पहले से कार्डियक डैमेज है उनका आपने ईसीजी भी करवानी है, कार्डियक बायोमार्कर्स भी करवाने हैं और एकोकार्डियोग्राम भी करवाने हैं। न्यूरोएंडोक्राइन डिस्फंक्शन में भी देयर sometimes there is raised intracranial pressure as well. This is a ventriculostomy. आप एक होता क्या है, आप एक ट्यूब डाल देते हैं and this tube is connected to this underwater seal और ये CSF जितना excess CSF होगा उसको ड्रेन कर लेगी। दिस इज अ वीपी शंट, आप एक शंट डालते हैं वेंट्रिकल्स के अंदर, लेटरल वेंट्रिकल्स के अंदर, and this shunt is attached to a tube which goes under the skin into the peritoneal cavity, and this CSF drains into the peritoneal cavity. Sometimes जब ventriculostomy या VP shunt possible नहीं होता, we may do a therapeutic lumbar puncture. 30 to 50 cc of CSF is drained. Remember, in our brain, up to 150 cc of CSF is present at one time. और एक दिन के अंदर 400 से 500 ml CSF प्रोड्यूस होता है। Sometimes there is brain edema and we need to use osmotic diuretics like mannitol. अगर इन सब चीज़ों के साथ भी हम इंट्राक्रेनियल प्रेशर को कम ना कर सकें, we have to resort to हेमिक्रेनिएक्टमी। हेमिक्रेनिएक्टमी के अंदर क्या होता है कि हम स्कल का एक पूरा फ्लैप along with the brain उतार देते हैं। We give space to the brain to expand, and when the brain goes down, the brain swelling goes down, we have to replace this skull. Sometimes the bleeding is so severe the patient may have anemia, and ultimately we need to treat this anemia. In patients with cardiovascular dysfunction, there may be myocardial infarctions or and STEMI, or sometimes unstable angina or pulmonary edema. So these investigations should be done in the hyperglycemia may be there, so we need to control hyperglycemia. Hyperglycemia की वजह से brain damage के chances बढ़ जाते हैं, vasospasm के chances बढ़ जाते हैं, brain ischemia के chances बढ़ सकते हैं. Hypothalamic pituitary dysfunction can be there, and we have to monitor for a syndrome of inappropriate IDH secretion. Sometimes fever is there, and whenever the fever is there, you have to identify infectious and non-infectious causes. Non-infectious fever may be because of damage to the hypothalamic pituitary axis, and infectious causes, if present, should be vigorously treated. Mortality is up to 22%, and morbidity because of hydrocephalus and cranial nerve palsies and seizures. It is there. There can be diffuse brain damage in some cases. So these are the morbidities that can be there in a patient of subarachnoid. Thank you so much for watching. We'll be uploading our next lecture of cerebral venous sinus thrombosis.